about all the statins which we are using today, atorvastatin and simvastatin has been shown to reduce the blood pressure, and this mechanism is different from their lipid lowering mechanism. So that is an information to you that if you are using atorvastatin and simvastatin, they may lower the blood pressure of the patient. And this is the goal which you set. Hypertension, goal of therapy is less than 140/90. The drugs which you can use, ACE inhibitor, ARV, or calcium channel blocker, plus alpha blocker. They have suggested limited use of diuretics and beta blockers. Beta blockers is definitely not in the front line nowadays, but with diuretic coronary artery disease. And this is the only, the thiazide or the diuretic is the only thiazide anti drug which takes care of your night dipping. So that is very, very important. I think that the learned people should think before writing off thiazide diuretics as a frontline treatment. And for dyslipidemia, I told you that for all practical purposes, if no risk factor, make it LDL less than 100. If there is established cardiovascular disease, make it less than 70. And how low, we do not know. How low is the low? So lower the LDL, better your chances of not getting cardiovascular disease. So with we can summarize in one way, the hypertensive and dyslipidemia in a patient is a deadly combination, and they both need to be treated very aggressively. Thank you very much.
Thank you, sir. If there is any question, floor is open for question and answer. Nothing, then we thank you, sir, for this wonderful session. So I think we go straight to the next session of a very important and interesting speaker, Dr. Sajjad Ehsan. So just let us know, Dr. Sajjad, what you don't want to tell me.
My warm regards and gratitude to course director Dr. Agarwal sir, Professor H.K. Chin sir, and my mentor and guide Dr. Ved Prakash sir, and especially my mentor, when I say mentor and guide, who always guide me, Dr. Subhash sir. So we had already a talk on this obesity and diabetes. So my topic is same, that how we can prevent and delay this type 2 diabetes. Dr. Ved Prakash sir has talked much, and he has given all the insights about that, how you can prevent the obesity. But I will discuss some important strategies considering this entire metabolic syndrome, lifestyle approaches, and there are some studies I will discuss. So when we talk about all the lifestyle diseases, just look at this tree. If you see the entire root cause of all these lifestyle diseases like the hypertension and the dyslipidemia, Dr. Professor N.P. Verma talked about, you see the obesity is the root cause of all these non-communicable diseases. And if you see the very famous INTERHEART study, which was by Salim Yusuf, which was published in 2004 in the Lancet, he talked about the 9 modifiable risk factors considering all these, specifically this myocardial infarction and coronary artery disease, and diabetes, obesity, tobacco, smoking were amongst the major important risk factors that was included that in INTERHEART study. And that INTERHEART study has a very good validation because that was conducted in the 52 countries across the globe. So let's talk about the diabetes, because this is a major burden. If you, Dr. Ved has already talked about this burden of the diabetes globally. This is the 9th leading cause of the death. And if you see that entire global population, almost 40% of the global adult population, meaning there were 422 millions. So this is a big number we are going to deal with in the upcoming days, and this number is going to double, almost double in the upcoming days. So what we talk about our own population, if you talk about the Indian population prevalence, this is the IDF data. We are just next to the China, that in terms of the number of figures we are having people with diabetes. In 2019, this was 77 million. But look at the projection. We are just going to be double in 2045. So this is a very major chunk of the problem. But what is very important, this is the submerged part of the population, that is the pre-diabetes, often unrecognized and submerged part, that if you see the prevalence, this is almost 7.3 in the entire global population, and it is almost increasing by 8.3 with impaired glucose tolerance or impaired this pre-diabetic population. But we have so many talked about the thrifty gene hypothesis amongst the Asian Indian phenotype. Dr. Verma has also talked about this thin fat Asian Indians, that what we are, why we are much more susceptible. Dr. Ved has talked about this intrauterine malnutrition and then surplus of the energy after the birth, and this can lead to much more susceptibility, both genetic as well as a familial aggregation towards the propagation of type 2 diabetes. So we are thin fat Indian with low birth weight, and this altogether causes a more inflammatory states in our body, more ectopic fat deposition, we had already so many things, more insulin resistance, and one very dyslipidemia was talked recently by Dr. Verma. So what kind of dyslipidemia we have? We are, if you see one very important study, that was ICMR India study in 2000. So this study was conducted across the 4 states of India, and what they have came out with this study, that we have a different kind of dyslipidemia also with very high triglyceride content. LDL is not as much as we see in our clinical practice, but that LDL is also atherogenic, a small condensed low LDL. That is more atherogenic and more with insulin resistance. So apart from all these genetic factors, what we see, we have, we cannot blame the genes also. We are going towards a more bad kind of the lifestyle with overweight, overeating, the kind of surplus of the food we are having in the last 2 decades, more sedentary habits. These are the important causative factors. That is why we are having a new term with diabetes, that is the diabeticity and the obesity. This is 67% of the population, if you see this diabetic population are obese. So that is why American Association of Clinical Endocrinologists, they come up with a new terminology for this obesity. They came up with ABCD. That is adiposity-based chronic disease. Obesity they have defined in this way. That is, if this is a chronic relapsing inflammatory disease, they have defined as obesity. So if you see the relationship between the BMI and the risk of diabetes, more in the females, more in the women, this is, they are having a more increased relative risk as you have a higher BMI. This diabetes and obesity, this inflammation hypothesis was very well discussed by Dr. Ved Prakash sir, and this I will not discuss in this detail. Adipokine hypothesis, this adipokine hormone, sir has already discussed. But what is important? Need for nutritional and lifestyle intervention, a very sustained, very simple thing what we need to keep in our mind is sustained weight loss, not transient. A sustained weight loss of almost 5 to 10%, that very definitely reduces the risk of or progression from the pre-diabetes to diabetes. So, but this is not only for diabetes. If you look at the entire spectrum towards what sir was talked about, the 11, 12 types of cancer. But simple things, if you see, just reduce 5% of the weight, it will improve your hypertension. Prevention of the diabetes, most of the guidelines they recommend at least a reduction of 7 to 10% of the weight loss. Even with another inflammatory conditions like PCOS, dyslipidemia, and what all the studies they talk about the diabetes remission. They talk just simple in most of the studies what we have the data. 15% of the weight loss that causes the reversal or the remission of the diabetes. So what is this reversal? Whether we can achieve it practically or this is just simply a fiction. So what is the reversal of diabetes? This is a reasonable goal in early diabetes where we try to reverse the underlying metabolic abnormalities for the achievement of euglycemic state and without the need of any glucose lowering medication. So this has been defined by American Association of British and Clinical Diabetologists that if fasting plasma glucose concentration less than 126 and A1C of less than 6.5 on 2 occasions separated by at least 6 months. and it should be occur spontaneously or following an intervention like a lifestyle modification or a dietary modification, but at least it should persist for at least 3 months. So what causes type 2 diabetes remission? So in 2008 we got with a twin cycle hypothesis that postulated that there is a vicious cycle of fat accumulation in the liver and pancreas that lead to the development of diabetes. Just try to understand this insulin resistance and beta cell dysfunction, that what is the importance of this pancreatic fat. Genetic susceptibility, overflow of the food, and the muscle insulin resistance. These are the basic 3 important pathophysiological factors which increases your hepatic de novo lipogenesis, that is the more lipid production, and this intrahepatic fat deposition and the filling out from your vessels. This resides at some ectopic sites, and when it has pancreas, this increases this islet exposure to more fatty acids, causes more inflammation there, more insulin resistance, and this leads to a different kind of state of this beta cell de-differentiation, we call it, where the beta cell goes in the stunned state. That may be a cause of your diabetes. So, but what is the solution? How we can prevent this type 2 diabetes? Simple things we need to understand: eat healthy, do some exercise, and try to lose your weight. But so for this, what is the role of nutrition and lifestyle? We had 2 very good papers that was published in the Lancet. One was the Look Ahead trial, that was the landmark trial, which I can say that was talked about that with intensive lifestyle control or with a good nutrition, how you can reverse the diabetes. Another paper we will talk about the direct open trial. So what was in the Look Ahead trial? These 2 subgroups they have taken with intensive lifestyle management and diabetes support and education. So I am not going to the detail, but the entire result, because this trial was done to find the cardiovascular outcomes, but with intensive lifestyle support, with average 8.6% of the weight loss, they got a very significant reduction in the A1C in that entire Look Ahead trial population, and there was established, this trial has established, there was the reversal from the pre-diabetic to diabetic state. There was a reduced progression to the pre-diabetic to diabetic state. Another trial, that was the direct trial, which was done for patients with diabetes on 6 years duration. In the intervention group, they have withdrawn all the anti-diabetic and anti-hypertensive medication. They put their patient on the very low calorie formula diet, considering 800 to 900 calorie up to 5 months, and what their results they got a very surprising results. They found the diabetes remission almost in 46% of the population in the intervention group, and this was a very significant data. So these 2 trials at least give us an insight that diabetes can lead to in a remission state by a proper weight loss up to 10 to 15 kg, because in these 2 trials they have done a very good intervention with regard to the weight loss. Another very study, that was a counterpart study, they have done also with a hypocaloric diet, that is up to 800 to 1000 kilocalorie, and in all parameters like fasting plasma glucose, with triglyceride glucose, the pancreatic TG content they have also calculated, they found a reversal. So these are some trials, counterpoint, counterbalance, and direct sub-studies. They are advocated, have some evidence that diabetes remission can be achieved in most of the individual if you do with a lifestyle and the low calorie diet intensively. So in those population, that how we can achieve diabetes remission, especially in the younger patient with short duration of the diabetes, they respond better. Patients with lower fasting plasma glucose, A1C, less drug requirement, they respond better, and because they have an early good beta cell function, and that is why they respond well. And weight loss up to 10 to 15 kg, that is the potential threshold for the diabetes reversal. Medical nutrition therapy, sir has also talked about this. This is a structured weight loss plan through medical nutrition therapy, and most of the studies they have demonstrated that variety of eating plans, considering your macronutrient composition, and if it is supervised by a registered medical nutritionist, they can help you in, and this is also advocated by the American Diabetes standard cares in 2019. But what should be the goal of medical nutrition therapy? It should not be that you just provide them with a low calorie diet. It should promote a healthful eating pattern, nutrient dense food with an appropriate portion size to address the individual needs, because we have a varied cultural differences, and that is why you need to provide, considering these cultural differences, practical healthy eating tools rather than just focusing on individual macronutrients. And at least the most important point, that you have to maintain the pleasure of eating by providing just this non-judgmental message about the food choices. One very important aspect I will discuss. This is a second meal effect. This was the first concept which was announced by 1982 by providing low glycemic index food by Dr. David J. Jenkins, University of Toronto. He defined the effect of first meal on the blood sugar level after eating the second meal. So if you give low glycemic index food in the breakfast, it will affect your postprandial response to your lunch also. If you give a low glycemic index food in the morning with breakfast, it will affect the postprandial glycemic response to your lunch also. Because in the low glycemic index food, in low second meal effect formula, they provide with more fiber in the food, high protein diet with low glycemic index food, and this leads to, suppose if you give a very high protein in the breakfast, consuming this high protein pre-breakfast and a snack, almost this results in 40% reduction of postprandial glucose increment. Because this high protein diet increases the satiety of your patient, that is mostly responsible for this least postprandial surge. And this medical nutrition therapy, considering of this high fiber formula, more protein, they stimulate your GLP, that is the key determinant of post-glucose hemostasis, slows your gastric emptying and helps you to stop overeating. So there are many evidences, many established evidences that medical nutrition therapy is very effective in reducing the A1C in the diabetes care. Pharmacotherapy, lastly we talked about metformin, because there is a potential contribution of the metformin in the metabolic syndrome also, just because of MAP kinase pathway, Dr. Ved sir has also talked about. But for this, ADA considers this drug in the pre-diabetic conditions, in certain conditions, like your patient is having BMI more than 35, fasting plasma glucose more than 10, HbA1c between 6 to 6.5, and if your patient is having prior GDM. So if you find 2 out of these criteria, you can use metformin, but there is some concerns with metformin. You need to periodically monitor the B12, but practically what we see that this is not always necessary. Anti-obesity medication, they do not work much in your patients apart from some bariatric surgery, but there are certainly drugs, Orlistat we have with the name of, this is approved for adult and adolescent obesity, and you can achieve with this 120 milligram thrice daily dose up to a weight of 5 kg. In this Zendo study, they have given this drug with lifestyle and diet therapy. And this reduced also risk to the progression of diabetes up to 37%. Liraglutide, sir has talked about the GLP-1 agonist. This drug, although what we use in diabetes, but this drug when they have evaluated in obesity with a 3 milligram dose, and this was approved by the FDA for adult obesity, and this has a proven efficacy, but in diabetes we use up to 1.8 milligram so this scale obesity and scale diabetes trial, they have also found that this drug can reduce a very good much amount of weight and helpful in reduction of the obesity also. And one very important drug that is least discussed, acarbose. This stop NITN trial, when they have done this trial in pre-diabetic patients, this drug has also shown 25% relative risk reduction in progression to the diabetes. So, but these drugs are not approved for this obesity management, but you can use it off-label in the diabetes management. But overall, if you see the obesity management and type 2 diabetes prevention, in comparison to healthy lifestyle, metformin and placebo, this is the lifestyle only which majorly impacts, and the cumulative weight changes with the lifestyle was much more than the metformin. That is why lifestyle modification is much more emphasized. But the only problem is that if you are not having a very good willpower, weight regain is very common after the initial weight loss. This is evident from the data. But regarding the bariatric surgery, most of the bariatric surgeries, whether it's gastric banding or the sleeve gastrectomy, these surgeries have also proved that diabetes remission can be achieved by most of these patients who have undergone surgery. But for this you need to have a certain practical consideration also, like in the Asian population they have cut down this category to 37.5 with comorbidities of your BMI. But for Western population they have an upper BMI. But overall, what the nutshell is message is, for prevention of type 2 diabetes, eat healthy, do some exercise, lose weight, and just follow this simple rule of 100, 50 and 25. Stop 100% sugar, reduce oil by 50%, 50%, reduce overall quantity of food by 25%. Exercise you can do as per your age and the capacity. At least 150 minutes of walk in a week is mostly recommended by the guidelines, and just by doing a simple weight loss of 10%, it reduces the loss of visceral ectopic fat by 30%, improves your all the markers like endothelial function, inflammatory markers, thrombosis risk, and specifically this you can have to change from this to this after this 10% of the weight loss. And the myth is that borderline diabetes is not very serious, but mind it, pre-diabetes is an indicator for future diabetes, and we have gastroenterologists also here. NASH is also, NFLD or NASH is a very important risk factor for your future diabetes and vascular complication also. But the entire thing is that what we can propagate to our masses, education is the most powerful weapon that we can use to change this world, and that is why we are all here to propagate this management about the lifestyle disease. Thank you very much for your patient hearing.
Thank you, Sajjad. It was a very nice presentation, and you have covered a lot of new insights on obesity. In fact, obesity was never considered as a disease. It's a very late that WHO and all, it is again a continuous process, and you have to keep on consulting the physician so that the regain doesn't happen. So I think if any question, yes sir, please.
Obesity is apparent.
About this thin fat Indians. And your one more question you have asked, I think in the last session, that was the thin fat Indians. Should it be applicable to the entire population of the India? So in that ICMR India study that was done in the four states of India, and the Jharkhand was also the part of that. Dr. Professor V. Mohan was the one part of the study. They have found this prevalence of this entire obesity 23%, and this visceral obesity 27%. So this is not applicable to the, because we have a varied kind of the population, but this is almost 25% of the data which we see in terms of normal weight obesity, 27% also. So, but other parameters also, that like the metabolic syndrome, other risk factors like the waist circumference, which was 90 considered in the male and 80 in the female, and certain other ectopic site fat deposition, another risk factors we need to see also, like NFLD also, high inflammatory markers. Considering the risk of all these diseases, metabolic disease we need to see in total, not just one single factor.
Problem is, if the man is having a normal weight and he has a visceral fat in excess, what dietary suggestion you are going to advise him? How can you ask him to go for a low calorie diet?
So for not provide individualized need of the patient, you cannot apply low calorie diet to the entire population. Just advise them to eat healthy, more fibers.
Yeah, okay, you are right, we can individualize. Yeah, where we can recommend high protein, low carb and low fat diet. Do you agree with me or not? Because it has its own implication. High protein, low carb and low fat diet has very serious side effects somewhere. You have seen it in Atkins diet also. What do you suggest?
The question is very tricky. If a person is not obese. So first of all, BMI is not a very good indicator, as Dr. was talking that it is the waist-hip ratio or abdominal obesity which should be measured separately for Asian population. And a diet, I think risk factor should be calculated, not only the weight or obesity, other risk factor like sir was talking. thin patient with bad history, like family history of heart disease or family history of pre-diabetes or diabetes, and other factors. If you see, I think from that's what the childhood obesity, or from the childhood itself, the training should be there so that a high risk population can be taken care. But then again, what diet and how to cut down, it is a tricky question, and you have to understand and explain the patient.
Visceral adiposity, as Dr. Subhash said, waist hip ratio is the best indicator. The another indicator is the subscapular and triceps skin fold thickness.
We are not talking about diagnosis. We have already said.
Will not be followed for a longer duration. So always a middle path is the best path.
My suggestion is we should try to work on it. We talk about it. We say that there is a thin fat Indian syndrome, and then we forget what exactly we should advise as patient to him. So we should make a group, right?
From high business class house child to every month 4 to 5 kg. At the 9 year, he was 93 kg weight. So what could be the
As you are telling that he has been already investigated at all the genetic genes responsible also, it have ruled out all the secondary causes of obesity in the child, all the hormonal like hypothyroidism,
all are done and all.
even the pituitary causes, hypothalamic causes like sometimes
MRI,
everything they have been ruled out. Probably what we can suspect, there are some genes responsible and some specifically, but before
I am telling you, done the counseling of the patient. From morning to night, उसका हमने हिस्ट्री लिया. वो 15 बोतल कोको कोला रोज पीता था. 3-4 कोर्स ऑफ आइसक्रीम. जब खेल कर आवे तो फ्रिज में से आइसक्रीम निकालते. आइसक्रीम कोल्ड ड्रिंक पीते. ये उसने 15 बोतल का डेली का उसका कंजम्पशन था कोल्ड ड्रिंक का. And that was the main cause. I asked him कि you empty your fridge, don't keep chocolate, ice cream and cold drink in your fridge.
साथ में बच्चों में सर कोई ट्रीटमेंट ऑप्शन नहीं है, फार्माकोलॉजिकल ऑप्शन कुछ
तो उसको जब हटा दिया तो
दैट इज द मोस्ट कॉमन
very important for any patient. You have to devote half an hour time.
Any other question? I think we have done a wonderful presentation, and I'll hand over the mic to the online.
Request Dr. Subhash to felicitate Dr. Prasad. Now may I request Dr. Verma to play Dr. Verma. I request now our course director. Thank you, Dr. Subhash. So with this, we'll break for lunch. The next sessions post lunch. So lunch is served behind. So request everyone to please join for the lunch.
बहुत अंतर है, सब थियरी है.
रोल ऑफ सर्वास्टिक का जो है
दोनों का ही सेम रोल था ना. कभी
हाँ ये बात तो है
नहीं लेकिन हम लोग के हम लोग के जमाने में उसके बाद भाई स्ट्रेटेजी
और आप लोग का नंबर मेरे पास है मैं बाद में व्हाट्सएप खाते वक्त कांटेक्ट बता के खा लेंगे ना
एडिट है ना
मुझे लगता देखिए जब तक
पेमेंट वगैरह नहीं करेंगे
आपको हमको
खाना नहीं खा रहे हो
A primer to the primary care physician. To moderate this session, I invite Dr. Ashish Jha, and our speaker will be Dr. Ramesh Kumar.
Ramesh Kumar is HOD in Department of Gastroenterology, AIIMS Patna, and he has a special interest in non-alcoholic fatty liver disease. He has published more than 100 papers in various journals, national and international journals. Over to Dr. Ramesh Kumar.
History of alcohol consumption or any secondary cause of hepatic steatosis. So, of course, majority of them has actually NFLD, that is non-alcoholic fatty liver disease. NAFLD has very exciting journey from a very irrelevant entity way back before 3 decades to the most relevant entity as of today. Only about 3 decades ago, we used to dismiss this condition as an innocuous entity, nothing to be done sort of thing. But then started, accumulating a plethora of data, which suggested that no, it is not an innocuous entity. And this is the scenario. NAFLD is the commonest cause of chronic liver disease, at least in the Western world. It is a 2/3 cause of cryptogenic cirrhosis. It is a 3rd commonest cause of hepatocellular carcinoma, and it is soon to become the commonest indication for liver transplantation. And there are so many diseases which has very strong association with NAFLD. So let us try to understand what NAFLD is actually. As the name implies, the NAFLD is intrahepatic accumulation of fat, which is mainly triglyceride. To be able to call it NAFLD, one should have at least 5% of liver by weight fat, which is equivalent to 5% of hepatocyte containing fat vacuoles on hepatic histopathology. So before labeling the patient as NAFLD, one needs to rule out history of significant alcohol consumption as well as secondary causes of hepatic steatosis. So what is this significant alcohol consumption? Although the suggested cutoff varies across the societies, as per the Asia Pacific guidelines, the suggested cutoff for male is more than 20 grams per day, which is equivalent to 500 ml of beer, 210 ml of wine, and 62 ml of hard liquor like rum, whiskey, and brandy. So these are the secondary causes of fatty liver. Commonly implicated drugs are amitriptyline, methotrexate, steroid, and there are certain diseases like SCV infection, especially genotype 3. So metabolic syndrome remains the commonest risk factor for NAFLD. As we can see here, 90% of individuals with fatty liver disease has at least one feature of metabolic syndrome, and full-blown metabolic syndrome is present in about 1/3 of NAFLD patients. Coming to clinical phenotype, there are basically two phenotypes of NAFLD. One is obese NAFLD and another is lean or non-obese NAFLD. The obese NAFLD is the commonest phenotype. These patients usually have obesity and features of metabolic syndrome in varying proportions. And this patient usually presents with pain in right upper quadrant abdomen, fatigue, and hepatomegaly. While the non-obese NAFLD remains largely asymptomatic and they are incidentally detected. These patients usually, as per the Asia Pacific cutoff, they have BMI less than 23. Although these patients are non-obese, metabolically many of these patients are actually obese, and some of these patients have genetic predisposition. So these are the pathological phenotype, which is commonly known as NAFLD. Previously we used to call it simple steatosis. Although this patient may have mild lobular inflammation, and the most sinister entity is NAS, which is non-alcoholic steatohepatitis. These patients usually have varying degree of nephroid inflammation, and ballooning degeneration is something quite characteristic. And this NAS has very high propensity to progress from the F0 fibrosis to F4 fibrosis, which is actually the cirrhosis. Of late, there has been a lot of controversy, rather a suggestion from international groups to rename this NAFLD to MAFLD, which is metabolic dysfunction associated fatty liver disease. Although this term has been used since 1980, so many criticism has been voiced because use of the term non tends to trivialize this condition, and because this is NAFLD is the commonest cause of chronic liver disease, so using terminology like non-alcoholic makes it poor fit to define such condition, and also it overemphasizes the use of alcohol while understanding the root cause, which is the metabolic dysfunction. Also, a negative diagnosis impacts its public interest. Weight or diabetes, we can straightforward make diagnosis of MAFLD. But once a patient has BMI less than 23, in this scenario, there has to be documentation of at least 2 metabolic abnormalities from this list. So what is in name? Actually, the MAFLD makes this entity gives this entity a positive diagnosis. It identifies patients with poorer prognosis because presence of metabolic dysfunction, metabolic syndrome gives poor prognosis to such patients. And also MAFLD allows coexistence with other cause of chronic liver disease. Like one patient can have MAFLD as well as alcoholic liver disease. And this combination is not possible once we use, rather we rule out alcoholic liver disease. So these are the points in favor of MAFLD, but the point against has been such name change has been done without, any new understanding of molecular pathogenesis. Also, NAFLD does not specifically address the most sinister form of NAFLD, that is NAS. And also, the NAFLD may miss out some of the patients who are very obese and patients having genetically acquired NAFLD. So as of today, the jury is still out, and whatever terminology one may use to choose to call, both are correct. Coming to global prevalence of NAFLD, there is a wide variation in prevalence rate from 6.3% to 51%, and this is because of different populations as well as different use of diagnostic modalities. So one of the largest published studies, which is actually meta-analysis of 86 studies from 22 countries involving more than 85 lakhs individuals, the prevalence of NAFLD was estimated to be 25.2%. And the highest prevalence was noted in Middle East and South America. The prevalence of NAS was quite less, at 1.5 to 6.4%. And as we know, the most important risk factor for NAFLD is obesity and type 2 diabetes mellitus. So obviously the prevalence of NAFLD as well as of NAS is quite high in these two conditions. We have data from India also. Last year only a meta-analysis of 50 studies was published from Shalimar, and look at the prevalence rate. Estimated pool prevalence is 38.6%, which is quite above the worldwide prevalence rate. And this defies our previous belief that NAFLD is a disease of Western world. Rather, it is quite prevalent in India itself. Even in community-based data, the prevalence rate was 28.2%. Prevalence rate in children is also very high, 35%. And if we extrapolate this data on adult Indian population, we can imagine 25 crores of Indians will have NAFLD. And one can imagine if 10% of this patient progresses to cirrhosis in the next 10 years, the number will be 2.5 crores, which is such a high number. Pathogenesis of NAFLD is quite complex and is still under, investigation. I'm not going in detail, but the basic concept is that NAFLD is a result of multiple hits process. The first hit is usually hepatic steatosis, which is believed to be triggered by insulin resistance. The most common source of fat is adipose tissue lipolysis. And once there is accumulation of fat, it creates a state of lipotoxicity, which results in impaired insulin signaling, mitochondrial dysfunction, systemic inflammation, and endoplasmic reticulum stress. The entire process is modulated by genetic predisposition, metabolic risk factor, dietary habit, physical activity, as well as gut flora. And entire things ultimately results in apoptosis and cell death, which results in progression from simple steatosis to NAS. And NAS is the sinister entity which has high propensity to go on to develop cirrhosis. As far as progression of NAFLD is concerned, the stage of disease is very important. The progression rate is much slower in simple steatosis and it is faster in NAS. In general, around 20 to 40% of NAFLD, that is simple steatosis, progress to NAS in 2 to 6 years. And once there is a NAS, around 10 to 20% will go on to develop cirrhosis in 1 and 2 decades. Progression rate, one stage fibrosis progression 14 years in simple steatosis, 7 years in NAS. So almost 2 times faster progression in NAS patient. NAFLD is important cause of cirrhosis, SCC, hepatocellular carcinoma. Although it normally SCC develop after development of cirrhosis, but in case of NAFLD, SCC can occurs even in non-cirrhotic NAS. Rather, the data from Japan has suggested that almost 40% of patients of SCC in contact with NAFLD have non-cirrhotic liver, and that is very significant issue. Risk factors for SCC NAFLD are elderly, male, positive family history of SCC, and abnormal iron indices. So these are the patients who may require surveillance, but no such data, no such guidelines exist as of today. NAFLD has a lot of extrahepatic associations. You take any disease and here it is. The commonest association are with cardiovascular disease, especially the coronary artery disease. Apart from hepatocellular carcinoma, there are a lot of extra hepatic malignancy which has a strong association with NAFLD, like colorectal malignancy, breast, gastroesophageal malignancy, pancreatic cancer, and renal prostatic cancer. Because the steatotic liver has poor ability to regenerate, so there is high risk of post-resection liver failure, which is associated with high morbidity and mortality. And also the steatotic graft, in case of liver transplant, is associated with high risk of graft failure. Many other diseases like diabetes, CKD, PCOD, obstructive sleep apnea, psoriasis, osteoporosis, sarcopenia, stroke has been associated with NAFLD. Now coming to screening of NAFLD, because this condition is so widely prevalent, still most of the international society are against screening of NAFLD in general population. This is mainly because of lack of data on the cost effectiveness. Although some of the society like Asia Pacific and Israel recommend screen NAFLD in high risk population, that is patients with obesity or diabetes mellitus. And the best screening modality is of course ultrasonography. What we can see here, the normal liver has ecotextures compared to the renal cortex. Vessels and diaphragm are clearly visible, while in fatty liver, the liver becomes brighter. It is more hyperechoic as compared to renal cortex. Vessels become less prominent and diaphragm become poorly visualized. And depending upon these changes, the fatty liver has been graded into grade 1 to 3. Although a normal liver on ultrasound doesn't rule out fatty liver, this is very important issue. Many of times we suspect fatty liver, but ultrasound turns out to be normal. This happens because of ultrasound is a quite operator dependent procedure. It is difficult to perform in particularly in obese subjects, which are the high risk factor for NAFLD. Ultrasound has poor sensitivity when hepatic fat is less than 30%, and it doesn't provide quantitative gradation. Just grade 1, grade 2, grade 3 doesn't have good correlation with the liver quantification of fat. Also, because the fatty steatosis is diagnosed on the basis of renal cortical ecotexture, so in case of renal parenchymal disease, the diagnosis of NAFLD may be difficult. And sometimes there may be some confusion between fibrosis and steatosis, because fibrotic liver also looks like hyperechoic. So unless operator is confident enough to identify the subtle coarsening of hepatic parenchyma, it may be misreported as a fatty liver. One of the important misconceptions among many physicians are, if in case of fatty liver, if liver enzyme is raised, patient may have severe disease. Rather, it is not true at all. And normal ALT doesn't rule out NAS, and elevated ALT cannot predict NAS or fibrosis. In fact, LFT may be normal in up to 50% of NAFLD, including NAS. So serum liver enzyme doesn't have any role in predicting severity of NAFLD. So there are many atypical biochemical abnormality can be found commonly in patients with NAFLD, and this may pose sometimes diagnostic dilemma and raise confusion about the coexistence of other diseases. Like many of such patients, up to 48% patient can have autoimmune markers positive. Although these markers are usually in low titer, and this appears to be epiphenomenal, so if once the titer is on the higher side, we must consider liver biopsy to rule out coexistent autoimmune hepatitis. Unconjugated hyperbilirubinemia is another thing which can be seen in up to 25% patients with NAFLD. And it is not Gilbert syndrome, mind it, because NAFLD is a state of increased oxidative stress, and now unconjugated bilirubin is actually very good endogenous antioxidant. So it is believed that this may be actually a favorable endogenous response. Abnormal iron indices can be seen in up to 60%, and it has association with hepatic fibrosis, SCC, and oxidative stress. Similarly, hyperuricemia is frequently observed in such patients. Coming to most important is when patient with NAFLD, whether the patient of fatty liver disease has significant disease or not. Presence of NAS is important, but more important is presence of liver fibrosis. And the gold standard is liver biopsy, but that is difficult to be performed because the liver biopsy is associated with the risk of complications, and many of these patients are asymptomatic, are not willing to undergo liver biopsy. So we have very good non-invasive tests for liver fibrosis, and 3 important recommended tests are FIB-4, NAFLD fibrosis score, and liver elastography. FIB-4 NAFLD fibrosis score, the calculator are freely available on the internet. One can use that. The FIB-4 has gained much popularity of late because of its simplicity. We need only 4 parameters: age, platelet count, AST, and ALT, and we can calculate FIB-4 score. And these tests are available at primary care physician also. So FIB-4 score less than 1.5 has very high negative predictive value of ruling out significant fibrosis. And recently the FIB-4 cutoff has been lowered down, and 1.3 has been found to be better to differentiate from advanced fibrosis to no fibrosis. In fact, there is a dual cutoff of FIB-4 has been suggested to rule in and rule out presence of advanced fibrosis. If FIB-4 score is less than 1.3, we can confidently rule out advanced fibrosis. If FIB-4 is more than 2.6, we can assume presence of advanced fibrosis. But still there's a gap where the patient can go either side between 1.3 to 2.6. So how this gap can be minimized? So definitely here we have to use some additional modality. So liver elastography is the of late, it has gone much popularity. We have various methods available. The most commonly used method is vibration controlled transient elastography. We have MR elastography and we have 2D sear wave elastography. The VCT is the commonest method which is used in our day-to-day clinical practice, and we can see there is a cutoff. If liver elastography, if liver stiffness is less than 6 kilopascal, we can rule out significant fibrosis. If it is up to 8, there can be F1 to F2 fibrosis, and if it is more than 8, that is 9 to 12, F3, and more than 12 is cirrhosis. And between these all 3 modalities, no significant difference has been found as far as studies has been concerned. FibroScan has additional advantage. It can give some semi-quantification of hepatic steatosis also. So this is known as a new technique. This is known as control attenuation parameters. So somebody is having steatosis less than 250. We can rule out significant steatosis, and if it's more than 350, there is a presence of severe steatosis. So once we use FIB-4 score, the intermediate, and then we apply, FibroScan, that is sequential use of FIB-4 followed by FibroScan, can minimize the patient in intermediate zone to a great extent, so that most of the patient can be categorized, can be differentiated from advanced and no advanced fibrosis. So this is the major advantage of FIB-4. This can be applied at the community level, and which can be used whether the patient needs to be referred to a higher specialty unit or not. If FIB-4 score is less than 1.3, there is a low risk. These are low risk patients. This can be managed at community level itself. If FIB-4 is more than 1.3, patient needs to be referred to hepatologist. So that next step, patient has to go for fibroscanning and if requires liver biopsy. Liver biopsy is gold standard, and it is the only modality which is available to diagnose NAS in patient with fatty liver disease. But problem is patient acceptance and risk of complication, and there is inherent limitations like sampling error and all. So diagnosis of NAS requires presence of steatosis, lobular portal inflammation, and bilonic degeneration. There's a scoring system which is known as CNR scoring system, and if score is more than 4, we can make diagnosis of NAS. Coming to management of NFLD, the crux of management is lifestyle modification. The role of pharmacotherapy is very limited. You can see here, we have to strongly recommend the diet and lifestyle change. The idea is to achieve weight loss. And we can see in this figure, there is a progressive benefit from weight loss 3% to 5%, 7% to 10%. Just 7% weight loss is very desirable because it leads to a resolution of NAS, and 10% weight loss can lead to fibrosis resolution. But important is the weight loss should be consistent. It should not be just transient. And so there are some guidelines which suggest that cut down calorie at least 500 kilocalorie per day can result in 5 to 10% of weight loss, and when it is combined with 30 to 60 minutes of exercise in 3 to 5 days per week. A large number of pharmacological agents have been tried and tested, but nothing conclusive, nothing has been found so far very effective, and none has been accepted universally in the treatment of the NAFLD per se. There are certain drugs which have a good future, which appears to have a future potential, but these are approved for other conditions, not universally approved for NAFLD. These are obeticholic acid, saroglitazole, SGLT2 inhibitor, and semaglutide. Some promising drugs still in phase 3 clinical trials are semaglutide, lanifibranor, and resmetirom. So these are the drug which has been found very effective in phase 2 clinical trial, but phase 3 trial is still going on. So we don't know. There has been many drugs which has found effective in phase 2 trial but failed miserably in phase 3 trials. So let us see what comes out of these phase 3 trials. The general concept of pharmacotherapy is the role. It is largely limited to metabolic risk factor. Any drug treatment for NAFLD per se will be off-label. The drug treatment should be considered only in presence of NAS, not in all patients with fatty liver disease. 2 drugs has been currently recommended in selective cases, like vitamin E has been recommended in biopsy-proven NAS, non-diabetic biopsy-proven NAS. Pioglitazone has been again recommended in biopsy-proven NAS, mainly in diabetic patients. So what is the role of vitamin in current practice? Both AS American and European guidelines has advocated its use in biopsy-proven NAS without diabetes. And this recommendation is mainly based on PEVENS trial, which was published in NEJM 2010, where vitamin E was found to be better than placebo in terms of resolution of NAS, 43% versus 19% in placebo. These are histological improvement actually, 2-point histological improvement. The resolution of NAS was actually 36% versus 21%, but the major disadvantage, the major flip side was there is no improvement in fibrosis score. So evidence supports use of vitamin E in patients with NAS without diabetes mellitus. Dose is 400 milligram twice daily, and its role in diabetic NAS and NAS with cirrhosis is less clear. Also, there is no clarity with regard to the dose, formulation, and duration of therapy. The long-term safety concern has also been raised because some of the studies have found increase in all-cause mortality, the risk of stroke and prostatic carcinoma with vitamin E. Coming to pioglitazone, pioglitazone has been found to improve insulin sensitivity and liver enzymes. It has been found to improve liver histology also in terms of improvement in steatosis, inflammation, and ballooning degeneration. But there has not been any significant effect on liver fibrosis. And also there has been very few randomized controlled trial of longer duration. And this is the drug with a lot of side effects, like there is a high risk of hypoglycemia, there is a risk of chronic pedal edema, atypical chest pain, and also, and that is why these drugs are not very commonly used. This may be considered in NAS with diabetes mellitus. Obeticholic acid is an analog of chenodeoxycholic acid. It is basically FXR agonist, which has important role to play in the regulation of bile acids, lipids, and glucose. Very famous trial, FLAME trial, was published in Lancet 2015, has found obeticholic acid to be better than placebo. It was used for 72 weeks duration, and only in interim analysis at 24 weeks, significant histological benefit was found. Even fibrosis reduction was found in 35% patients, but this was phase 2 trial. So phase 3 trial, which is the Regenerate trial, is still going on. Interim result was published last 2-3 years ago, and we can see there is an improvement in fibrosis, but in primary endpoint, NAS resolution was not seen. Only in post hoc analysis, authors claim that there has been improvement in NAS also. But look at the response rate compared to placebo. Fibrosis improvement only 23% in 25 milligram dose and 17%. So as high as 80% of patients did not respond. So this is the scenario. And also there are a lot of safety concern with obeticholic acid. There is a significant risk of pruritus, particularly when doses are used more in 25 milligram per day. There is a risk of atherosclerosis, and there is a risk of gallstone also. And also obeticholic acid has been found hepatotoxic in animal studies. And these are the reasons this obeticholic acid has not been able to achieve FDA clearance so far. Although the final result of Regenerate trial is still awaited. Saroglitazar is available in India. It is dual PPAR alpha gamma agonist, which improves lipids and glycemic parameters. And one randomized controlled trial was published in Hepatology last year, which found it to be better than placebo in terms of reduction in liver fat and improvement in metabolic parameters. Although this data there was no histological data available. So the most important outcome has to be improvement in fibrosis, which was not assessed in this study. So this is the major drawback of this study. There is a study from India also. There is a study from Punjab where saroglitazar was used in diabetic dyslipidemia with NAFLD. And it was found to improve transaminases, liver stiffness, and steatosis. And probably based on this study, saroglitazar has been approved by BCGI India for NAFLD with comorbidity. And currently it is being tested in India by AIG in a large randomized controlled trial, which is still ongoing. Finally, the role of bariatric surgery. This one option is available for morbidly obese subject, because this is the way to achieve weight reduction in significant proportion and improvement in metabolic parameters. Although there is no randomized controlled trial, in a recently published studies, bariatric surgery has been found, has given very promising result. That resolution of NAS was found in as high as 84% of patients, and fibrosis was also decreased in 70%. Only problem is use of bariatric surgery in advanced fibrosis and cirrhotic NAS, where it poses the major safety concern. So a clear treatment study for NAFLD is yet to emerge. Many unanswered questions are there, like at what stage patients should receive therapy, what should be the ideal treatment target, what to use, single drug or combination therapy, what should be the duration of therapy, and what are the predictor of response, or is there any stopping rules. So we have to wait for the robust data to come to answer all these questions. Finally, this is my summary. NAFLD/MAFLD is the most common cause of chronic liver disease worldwide. It affects around 25% of population. Around 1/3 of NAFLD has NAS, which is the sinister form, and NAS, 1/4 of NAS progress to cirrhosis. Cardiovascular disease and malignancy are the major cause of death. It is not liver disease, rather extrahepatic condition. Non-invasive marker like FIB4 can be used to predict liver fibrosis and can be used for referral to a hepatologist. Lifestyle modification is the mainstay of treatment, and role of pharmacotherapy is delivered. Thank you very much.
Thank you, Dr. Ramesh Kumar, for such a wonderful lecture. Now, session is open for House. If any question from audience. As there no question, one thing I would like to add, FIB4 score is very easy to calculate. It's online available, so we can calculate